Assalamu alaikum. This is Dr. Amna, and this presentation is about preterm labor and birth. Preterm labor and preterm birth, we know the definition because when patient is having contractions and labor pain before 37 completed week, it's preterm labor, and then PPROM, we know that leaking before 37 weeks and without sign of labor, it's called PPROM. So this guideline is basically about the management of preterm labor and birth. So in this guideline, some patients are there for the there's a top article in which they have mentioned that there are some intermediate risk patients for the preterm labor and the high risk patient for the preterm labor. So they have given the criterias, like if the patient is having the previous history of large loop excision of transformation zone or bone biopsy or knife biopsy, and if the patient is having cesarean at full dilatation, she is having the moderate risk of having preterm delivery in this pregnancy. So these patients are being referred to the preterm prevention clinic at local or tertiary care. So they are screened there for the cervical length between for the intermediate. They have said that patient should have been screened for cervical length between 18 and 22 weeks. Once one reading will be done, and then patient will be under surveillance and to look for the sign of preterm labor, and patient will be educated and where to contact if she has the issues with the preterm labor, and she will be given information regarding sign and symptoms of preterm labor. So and also they have mentioned the patient who are had high risk of preterm labor, like patient who are having previous history of preterm labor before 34 weeks, or any loss of pregnancy after 16 weeks, and there's a history of PPROM in previous pregnancies, or also there's a history of cervical sac large in the previous pregnancies. So these are all the high risk of the having preterm delivery in this pregnancy. So these patients are also referred to the preterm prevention clinic, and there they will be having their cervical surveillance from 16 to 24 weeks. And this surveillance will be done 2 to 4 weekly. They want to see whether there is a shortened cervical length. If there is shortened cervical length below than 2.5 mm and 2.5 centimeters, so then they will give the certain management to prevent for prophylaxis management for the prophylactic management for the preterm labor. So previously we do not give the uh, preterm we do not give the progesterone for the prevention of preterm labor, and there are these recommendations have been changed in this guideline. So now we will discuss this guideline. So keeping in mind that these patients have already been screened, they have a known risk of preterm labor, and these patients have already been screened for the cervical length, and now the cervical length is less than 25 mm or more than 25 mm. How we will, what are the recommendation to deal with these patients who have been diagnosed with cervical length of 25 mm or less or more? So, according to Embrace UK 2021, according to 2021 Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries across the UK, report on perinatal mortality. Women from some minority ethnic backgrounds or who live in deprived areas have an increased risk of stillbirth and may need closer monitoring and additional support. Now, there is a new guideline about the small for gestational age. So in that guideline, they have incorporated the babies life care bundle. And in that, they have mentioned all the points which can be helpful to decrease the perinatal mortality, which include the prevention of small for gestational age and prevention of early diagnosis and management and prophylaxis of the preterm labor. And also there are other points, like 4 other points, like diabetes control and the smoking cessation. So and the educating the patient about the managing the risk factor of the SGA. All these points were incorporated in the SGA guidelines. So in the future video, I will also discuss about the small for gestational age guideline as well. So all these guidelines about the basic aim is to reduce the perinatal mortality and the obviously, so they have found that ethnic background important. So ethnic background is itself is not basically because of because they are deprived of proper nutrition, and some ethnicity are having trouble in finding all the resources for better health care and proper food, and so these things are basically related to the perinatal mortality. So the report showed that across all births, not just those who are which are preterm, so these are all perinatal deaths. Compared with white babies, 32 out of 10,000, the stillbirth rate is more than twice as high in black babies. Like in white babies, it's 32 out of 10,000, and in black babies, 72 out of 10,000 die. And around 50% higher in Asian babies. In Asian, 51 out of 10,000. These can be the question in the part 2 exam as well. And compared with the least deprived areas, 23 out of 10,000, stillbirth rate is twice as high in the most deprived areas, 47 out of 10,000. So I have mentioned that this guideline is about the patient has been screened for the because she's having the she's the been labeled as having increased risk of preterm labor in this pregnancy. Now patient has been screened for the vaginal cervical length. Now cervical length, should be done by TBS and by empty bladder, by after emptying bladder. And if it is done with full bladder, there will be falsely there can be impression that cervical length is long. So it should be done by TBS after emptying the bladder. So now the patient has we have the cervical length. So we will offer a choice of prophylactic vaginal progesterone or prophylactic cervical cerclage. We will give the option of both to the patient who have both. The patient should have these both. So that's why we will offer the patient about the choice of whatever she wants between vaginal progesterone and the prophylactic cervical cerclage. If she is having a history of spontaneous preterm birth up to 30 plus weeks of pregnancy, or loss from 16 weeks of pregnancy onwards, and simultaneously she is having the result from transvaginal scan carried out between 16 and 24 weeks of pregnancy that show the cervical length of 25 mm or less. So 25 mm is also reduced or less. So in these patients who have these two histories, we will give the option of both prophylactic vaginal progesterone and cervical cerclage. So she can choose any method if she wants. So she's being offered about this. Now we will discuss the risk and benefit of both options with the woman and make a shared decision on which treatment is most suitable. In April 2024, the only licensed preparation of progesterone for this indication was vaginal 200 milligram capsule. So consider prophylactic vaginal progesterone for women who have either. Now that was offering the both method to the patient who have both criteria, like she's having preterm and labor or early loss of pregnancy, and she's having cervical length, reduced cervical length. We will give her the both option. Now these are the patient who have one thing. Either they have history of spontaneous preterm birth up to 34 weeks or loss of 16 weeks of pregnancy onward, or she is having the result of the transvaginal scan carried out between 16 and 24 weeks of pregnancy that shows cervical length 25 mm or less. If patient is having one thing, then we will consider for vaginal progesterone, prophylactic vaginal progesterone to this woman. When using vaginal progesterone, start treatment between 16 and 24 weeks when you receive the result of TBS, 24 week of pregnancy, and continue until at least 34 weeks. Now there is another scenario that consider prophylactic cerclage. That was considered vaginal progesterone. Now consider prophylactic cervical cerclage for women when results of TVS carried out between 16 and 24 weeks of pregnancy show a cervical length of 25 mm or less. Now we have TVS, and also she must have one of these things, like she has history of pre-prom in the previous pregnancy, or history of cervical trauma. If any one is there, and she is also having cervical length, reduced cervical length with the PPROM or with the history of cervical trauma, she will be considered for prophylactic cervical cerclage. If prophylactic cervical cerclage, whenever is used, ensure a plan is made and documented for removal of the suture. Now, this is the history of, this is again that those 3 points I have mentioned in this small form, like history of spontaneous preterm birth up to 34 weeks of pregnancy, up to 34 weeks, or pregnancy loss from 16 week, and TVS between 16 to 24 weeks show cervical length 25 mm or less. Then we will offer vaginal estrogen or cervical cerclage. We will offer both, and patient will choose. We will discuss the pros and cons, and then we will make the informed decision. History of spontaneous preterm birth up to 34 weeks of pregnancy loss, or pregnancy loss from 16 week, or TVS between 16 to 24 weeks show cervical length 25 mm or less, then we will consider vaginal estrogen. So these points are very important, to whom we are offering and we are considering. TVS scan between 16 to 24 weeks shows cervical length 25 mm or less, and who have one thing between two, like who have pre-prom in pregnancy, or she has history of cervical trauma. We will consider cervical cerclage, and when we will make, we will do cervical cerclage, we will make the plan and written form that when to remove the cerclage. So this is the prophylaxis. Now, if the patient has presented with preterm pre-labor rupture of membrane, so how we will diagnose that patient? So if patient is giving the history of PPROM, she comes to us and she says that she has a leaking. So first we will take, obviously we will do the history examination, but I am discussing here the specific points for the diagnosis of preterm labor. So when we have these stations in part 3 exam. So we are supposed to do from the start, because patient is there. We will discuss history and any risk factor in the history, family history, and we will discuss about the neonatal care, gestation, and we will involve the obviously neonatologist in this discussion, so that to see the prognosis of the baby if born early. So if a woman reporting symptoms suggesting of PPROM, offer speculum examination to see amniotic pool. If you are able to see the amniotic pool, then it means it's preterm pre-labor rupture of membrane. You do not have to do any further test. But problem arise when there is a history, but you cannot see the pooling of amniotic fluid. So if pooling of amniotic fluid is observed, do not perform any diagnostic test, but offer care consistent with women having PPROM. If pooling of amniotic fluid is not observed, perform an insulin-like growth factor binding protein 1 test or placental alpha microglobulin 1 test for vaginal fluid. If test is positive and no amniotic pool is seen, then also take into account her clinical condition, medical and pregnancy history, and gestation age. Offer care consistent with women having PPROM, or reevaluate the woman's diagnostic status at a later point. So now tests are positive, you cannot see the amniotic pool, and you are observing the patient and still she's no leaking. You will see the general health of the patient. You have two options. If you can give the patient care for the PPROM, or you can reevaluate the patient woman's diagnostic status at a later time point. This discussion will be done with the consultant, so that informed decision will be informed decision will be made by patient woman and the consultant and neonatologist. If test is negative and no amniotic pool is seen, so do not offer prophylactic antibodies. Explain to woman she should come back again if any further symptoms appear. So do not use nitrazine to diagnose PPROM. Do not perform diagnostic tests for PPROM if labor becomes established in a woman reporting symptoms suggestive of PPROM. So now she has labor, she will go into labor, and the next management will be obviously steroid, magnesium sulfate, but we will not do the whole, like we will check the check for chorioamnionitis and other things because we don't want to manage this patient conservatively. She's going into labor and we will monitoring accordingly. So antenatal prophylactic antibiotic for women with PPROM. So these are the patients with the PPROM who are not in labor, and we are planning to manage these patients conservatively. So when we have a patient came, say at 29 weeks, so we did the pool test speculum examination. We see the pool, or we have seen the tests are positive, and we have made diagnosis that patient is having PPROM. So we will, as a prophylaxis for intrauterine infection, offer women with PPROM oral erythromycin 250 milligram 4 times a day for a maximum of 10 days, or until the woman is in established labor, whichever is sooner. If she is in labor after 4 days, then stop the erythromycin. If she is in labor at the 12 day or 13 day, and you will stop the erythromycin at 10 day. For women with PPROM who cannot tolerate erythromycin or in which erythromycin is contraindicated, consider an oral penicillin for a maximum of 10 days or until the woman is in established labor, whichever is sooner. Do not offer women with PPROM coamoxiclav or prophylaxis for intrauterine as prophylaxis for intrauterine infection. Okay, use a combination of clinical identifying infection in women with PPROM. Now we have given the patient with PPROM, we have given prophylactic antibiotic, but we have suspicion that patient may have infection. So use a combination of clinical assessment and test like C-reactive protein, white blood cell count, and measurement of fetal heart rate using CTG to diagnose intrauterine infection in women with PPROM. Do not use any of these in isolation. It's not like we will only rely on WBC or we will only rely on C-reactive protein. We have to do all these tests, and we will consider the situation by collectively patient condition and these tests. Then we will make the further plan. Do not use any of one of these in isolation to confirm or exclude intrauterine infection in women with PPROM. If the result of clinical assessment or any of the tests are not consistent with each other, continue to observe the woman and consider repeating the test. So now about the emergency cervical cerclage. It is done for the preterm labor whenever, but we do not do with the ruptured membrane. Emergency cervical cerclage will not be used for ruptured membrane. Do not offer emergency cervical cerclage to women with signs of infection, active vaginal bleeding, or uterine contractions. Consider emergency cervical cerclage for women between 16 and 26, 7 plus 6 weeks of pregnancy with a dilated cervix and exposed and ruptured fetal membrane. So emergency cervical cerclage is the point. Decision should be made with the discussion with the consultant obstetrician and consultant pediatrician. Take into account gestational age, being aware that the benefits are likely to be greater for earlier gestation and the extent of cervical dilatation. Consult the woman about risk of procedure, intended benefit. If emergency cervical cerclage is used, ensure that a plan is made and documented for removal of suture. So this was about management of PPROM. Now about the preterm labor. Patient comes with the history of preterm labor. So how we will diagnose this patient and how we will, what if patient is diagnosed, what extra care we will give to this patient. So offer a clinical assessment to women reporting symptoms of preterm labor who have intact membrane, proper detailed history examination. So we will clinical history and speculum examination followed by digital vaginal examination if the extent of cervical dilatation cannot be assessed. Be aware that if a swab for fetal fibronectin test is anticipated, the swab should be taken before any digital vaginal examination. Because when you have done speculum examination, you are not able to see any dilatation and you are having doubt the patient is having preterm labor or not. So first you want to do the test. You first take the swab for fetal fibronectin, because once you do the digital examination, so the fetal fibronectin level will be raised because of vaginal examination. So this is the chart for suspected preterm labor. So from the 20, we divided into the management of a patient with the 29 plus 6 weeks or less and 30 weeks or more. If the patient is less than 29 plus 6 weeks or at 29 plus 6 week or less than and she comes with the history of preterm labor. So we will advise treatment for preterm labor. We will not do any diagnostic test, and we will give the treatment for preterm labor. But if patient is at 30 weeks or more, now we will have to diagnose it by test if there is no clear-cut symptoms, and we have to diagnose by TBS for cervical length. If the cervical length is less than or equal to 15 mm, because do not forget that for the prophylaxis of um, preterm labor, there was a cutoff of 25 mm or less at 16 and between 16 and 24 weeks. So this is at 30 weeks. When we do the TVS for cervical length less than or equal to 15 mm, diagnosed, it is a diagnosed preterm, likely to deliver in 48 hours, and we will offer treatment for preterm labor. If cervical length is more than 15 mm, then unlikely to deliver, and reassure going home, reassure the patient, and we will discuss for the pros and cons of going home and hospital stay. And we can also look for alternative diagnosis and report if symptoms reoccurred. If the patient is not willing for the TVS, she is not accepting it, and or TVS is not available, then we can have option of fetal fibronectin. For first choice is the TVS, and if TVS is not accepted or declined, then we will have fetal fibronectin. If the fetal fibronectin level is more than 50 nanogram per ml, or less or equal than 50 nanogram, then if it is more than 50, then diagnose preterm, then offer treatment. If less or equal, then unlikely to deliver. So again, unlikely to deliver, we will discuss, reassure the patient, and we will discuss between staying in hospital and going home and alternative diagnosis, and we will tell the patient to report if there's any symptom recurrence. Do not use fetal fibronectin and TVS together. If TVS and fibronectin are not available or declined, offer treatment. So what treatment we will offer? This is how we diagnose the preterm labor. Now, what treatment we will offer to the patient? There's a tocolysis and steroid cover and magnesium sulfate, but there are age limit for each treatment, and there are some recommendations. And so these are the recommendations. As for tocolysis, take the following factors into account when making a decision about whether to start tocolysis: whether the woman is in suspected or diagnosed preterm labor. Offer clinical features. Other clinical features. What are the other clinical? For example, bleeding or infection, because we will see if there's a bleeding and there's a risk of abruption. We will not do the tocolysis. So if there's infection, we will not do the tocolysis either. That so other clinical features that may suggest that stopping labor is contraindicated. So gestational age at presentation. Likely benefit of maternal corticosteroid. Availability of an appropriate level of neonatal care. For example, if the patient, if we are expecting that neonate might need an ICU care or neonatal. So when we check in our hospital neonatal ICU, we see there is no bed availability, and we need to transfer that patient. So in that is also important, because there is we cannot monitor the patient here. We need to stabilize the patient, and we will shift the patient to the nearby facility. But this should be done in a proper manner. We will first check there is bed availability in neonatal ICU, and there's a bed availability in the obstetric department as well. So we will transfer the patient with proper referral and proper documentation and proper team, and they will hand over the patient there, and we will talk to the consultant in the relevant in the next hospital, and we will inform our consultant. This is also this is also a station in the part 3, where you will have a discussion with your consultant regarding that patient is in a preterm labor, and there's chances the baby need the ICU care, but there's no ICU bed available. So we need to transfer that patient to the ICU. So there's a different step in that care, like if right now, if we'll transfer, what will be our management, and if the patient become fully dilated right now, and how we will transfer or not, and if we do not transfer, then how we will transfer the baby. So that is a huge discussion about that. But here they have mentioned that we should know that baby need the appropriate level of care is available in our hospital or not, and the preference of the woman, obviously. So if we choose to do the autocolysis, then it is being done with nifedipine 20 from the 24 weeks to 25 plus 6 weeks. These weeks are very important, and we should remember whether we consider or offer or recommend what will be we do. So 20 from 24 weeks to 25 plus 6 weeks for women who have intact membranes are in suspected preterm labor, we will consider autocolysis with nifedipine. If a patient is between 26 weeks to 33 plus 6 weeks, we will offer autocolysis for the women who have intact membranes are in the or are in the and are in suspected or diagnosed preterm labor. If nifedipine is contraindicated, offer oxytocin receptor antagonist for autocolysis. Do not offer beta mimetics for autocolysis. Now the maternal corticosteroids, we need to give these for the prevention of neonatal complications. So women are in suspected or established preterm labor, are having a planned preterm birth, or have PPROM regarding corticosteroids. So whenever we discuss the preterm delivery, this is not only the patient who comes with the preterm labor, it's also the iatrogenic can be the, because patient is having uncontrolled preeclampsia or eclampsia, or patient is having some other small for gestational age or other any complication. So we need to expedite the delivery at in the preterm stage. So in those cases, we also need the maternal corticosteroids. So in this case, we have planned preterm birth. So this is a point where we say we have a planned preterm birth or have PPROM, or regarding corticosteroid from 22 weeks to 23 plus 6 weeks, we will discuss the maternal corticosteroid to the patient. And from 24 weeks to 33 plus 4 weeks, we will offer steroid. And from 34 weeks to 35 plus 6 weeks, we will consider corticosteroid. From the 24 weeks, 22 to 23 plus 6 weeks, there are very less chances for the baby to survive. But as we have in the part 1 exam, they give us the question about the Bolam principle and the Montgomery rule. So we know about the Bolam and the Montgomery rule, because in the Bolam, we know that a patient, doctors counsel the patient about the side effects of a particular treatment or procedure to the patient. And doctors tell the complication which doctor thinks is important. Like if there was a case in which a woman named Montgomery, she was having she had delivered the large for gestation age baby, and she was told about that baby will have brachial plexus injury, or for if she choose the vaginal birth, there is chances that baby have shoulder dystocia and baby can die, or she can have increased risk of cesarean section and brachial plexus injury. So she says, okay, I can accept all these things. So she opted for general delivery, but none of this happened. The baby was, when baby was born, baby was having cerebral palsy. So she was very angry, and she said, you did not tell me about cerebral palsy, because this is the thing which I cannot accept at any cost. If you have told me this before the procedure, at the time of consent, I should have opted for cesarean section. So at that time, there was this was a Montgomery ruling in which doctors are supposed to give all the information to the patient. Maybe doctor think this is not so important, and these are very minor risk, or but there are still the incidents of thing which a doctor think is not very important to mention, but for the patient's point of view, that can be important. So from the 22 weeks to 23 plus 6 weeks, the patient can claim that I was not given the choice of maternal corticosteroids. So we will discuss it with the patient, and the consultant will be involved in this discussion, and what will be the proposed benefit, and how will it affect about the prognosis of the child. So second shot of maternal corticosteroids, once you have given the one course of corticosteroid, whether we can give the second shot or not. So in this guideline, they have said that consider a single repeat course of maternal corticosteroid for women less than 34 weeks of pregnancy who have already had a course of corticosteroid when this was more than 7 days ago. So we can repeat single course, repeat course, if the patient has last steroid course more than 7 days ago, or at very high risk of giving birth in next 48 hours. Whether the woman is less than 30 weeks and pregnant, or if there is a suspected growth restriction, already patient is less than 30 weeks, or there is a suspicion of suspected growth retardation. Take into account the possible impact on fetal growth of a repeated course of maternal corticosteroids. Do not give more than 2 courses of maternal corticosteroid for preterm birth. When offering or considering maternal corticosteroid, discuss the benefits and risk with women. Regarding magnesium sulfate for neuroprotection, women who are in established preterm labor or having a planned preterm birth within 24 hours, regarding IV magnesium sulfate for neuroprotection of the baby. So from 23 weeks to 23 plus 6 weeks, we will discuss this with the patient, and from 24 to 29 plus 6, we will offer magnesium sulfate, and from 30 weeks to 33 plus 6, we will consider magnesium sulfate. Give a 4-gram IV bolus of magnesium sulfate over 15 minutes, followed by IV infusion of 1 gram per hour until the birth, or for 24 hours, which is sooner. So for women, because this is the same dose we used to give in the to prevent the imminent eclampsia, or in the prevention of the fit in eclampsia. For women on magnesium sulfate, monitor for clinical signs of magnesium toxicity at least every 4 hours by recording pulse, blood pressure, respiratory rate, and deep tendon reflexes, for example, patellar reflexes. If a woman has or develops oliguria or other evidence of renal failure, monitor more frequently for magnesium